you will be over-treating some of your patients. And if you looked at the data sets, there were 10% patients who actually were not malignancies, and they ended up getting chemotherapy, which is non-pardonable, that you're trying to treat a non-malignant condition with chemotherapy. So this is a worry always. So you're going to overexpose to chemotoxicity, and you may not have required it. And the main thing, we don't still have phase 3 data. We just have phase 2 data. One of the phase 2 data sets, this was a neoadjuvant study. Look at the number size. It's just a 57-patient study, which has been quoted so many times. And this is the biggest study. The other study which was quoted is just 28 patients. But this is a 57-patient study. They got neoadjuvant GEM-CIS. It could be even a split-dose CIS, depending on the creatinine clearance. They got 4 cycles, and then they go undergo surgery. But what we saw, 70% of patients completed the 4 cycles. 89% were able to complete 3 cycles at least. All of them went to surgery. No one progressed, so that's good to know. That's what we worry about. We give chemo and the patients progress. You lost the chance of cure, but that's not happening. 63% patients had a pathological response, and pathological response is less than PT2. 19% patients had a complete response. That's what we always want to achieve as oncologists when we see YP T0N0 is something we always love to see. But what is important is these curves. If you see the left side curves, at 3 years, the 2-year PFS was somewhere about 78%, 2 years OS 93%. But that's not the great part of it. The great part is the right side curves. You can clearly define those two populations of patients. Those who get pathological response, less than YPT2, you see their survival is clearly up there. And those patients who had more than YPT2 residual disease, their survival is clearly lesser. And of course, if you had PAT-CR, nothing better, their survival is right flat on top. And that's the whole advantage of neoadjuvant therapy. You are prognostifying your patients, but you will move further to the next level, and you'll start using this as a prediction tool to say, can I do something better in the next steps? But whatever we say, whether we do adjuvant or neoadjuvant, chemo is there to stay in upper urothelial bladder cancer. All of us have accepted this, but we move forward. A quick meta-analysis. This is all about studies pulled together. Again, I don't think you can really compare meta-analysis. It just says that it is really advantageous. Neoadjuvant chemo does do better, but adjuvant chemo does better with better, robust data. So I think all of us know the advantages and disadvantages. So we do chemo, but what we do more, and this is where we moved to, immunotherapy is here. And we saw this and we discussed this yesterday, the Checkmate 274 for bladder cancer, adjuvant nivolumab for 1 year after your treatment. Those were patients who got neoadjuvant chemo, had more than PT2 disease, had surgery, and then 1 year of nivolumab. Or those who were unfit, got surgery, and then have more than PT3 disease. They all got adjuvant 1-year nivolumab. And we've seen the data set. We've seen there's a clear improvement in disease-free survival. The hazards are clearly significant, and it is approved. And I think all of us have started using it for our high-risk patients. Of course, the PD-L1 population did even better. So why don't we extrapolate it to all patients of upper urothelial tract cancer? It's there in the trial. It was done. And if you look at the forest plots, every subgroup of patient in this trial benefited except one subgroup, and that was the upper urothelial tract cancer. And if you magnify it on the right side, that population did not show benefit to immunotherapy, and that kind of beats us. It should not be happening. That's not what we expect to happen. For 2 reasons, I didn't expect this. Upper urothelial tract cancer is the ones you actually expect maximum to be Lynch. That's where, and for us, Lynch and MMR deficiency in cancer, in medical onc has become any cancer anywhere in the body, MMR deficiency, give them immuno and they will work. To the extent that in rectal cancers, MMR deficiency, you give neoadjuvant immuno, you're not operating them, you're not doing anything, you're just observing them because you get such a high PAT-CR rate. So this amazes me, but I think we haven't read the whole text, so we will know what segment was Lynch in this, and I expect there will be nothing in Lynch. Otherwise, this would never have come out this way. But again, is it the biology or is it just the numbers? And I think it could just be the numbers, but we'll see with more data coming out. So my last slide, I think chemo is here to stay. Whether you do neoadjuvant or you do adjuvant, you will have to nuance that decision according to your patient population and your patients, what you see as in your practice. And I think it's the uro-oncology surgeons who are actually going to take that decision, what they think, which side they're going to put their patients into. There is a randomized trial which will report, and that will probably give us a clearer answer. I think we are looking at further approaches. Biomarkers are getting more and more important. I further think post-neoadjuvant, using tools to understand which patients will do further better and which require further escalation in treatment is important. And I think the era is going to change. I think this is the last year we'll be sitting and debating this. Immuno is going to make a space. It's moved from the palliative stage 4 setting to the adjuvant setting. And if you've seen, there are already phase through neoadjuvant data have already started reporting out. And if you see the PAT-CR rates, they're so amazingly high that we will be integrating immuno into the neoadjuvant space, and all these trials will become the base of our treatment, but eventually it will move forward. Thank you very much.
We have 4 minutes for discussion.
In our experience, what you have told is very correct. The adjuvant setting, the chemotherapy works very well. But in the neoadjuvant setting, most of the high volume tumors, they have a very poor outcome. But the low volume tumors in the upper tract TCC, they do better. So do you like to advise us what should be the best procedure if the high volume tumors can be proceeded with the surgery and they are subjected for the adjuvant chemotherapy?
Ideally, if you look at the phase 2 data sets, it's the high volume which will actually require the neoadjuvant chemo, and that's the one you can downstage even better. So I think a good, well-given GemCis does work well. But yes, we clearly agree GemCis is not the best in the present era. We need to get better than this. At least the phase 2 data clearly shows all the patients they took in, everyone responded. No one progressed, and they all went to surgery with some of them having good response, some of them not having good response. But this is something that all of us will have to see whether we are able to adapt for our patients in practice. Okay. The giving of chemo becomes an issue, and that sometimes changes our results.
Okay, thank you.
Gil here. Thing is, we always prefer to have a neoadjuvant in the upper tract setting, but the limitation for us is to get a biopsy. So are you happy to have a neoadjuvant with a radiological picture or at least a cytology, or you are telling that I have to get a biopsy? Because as a surgeon, we are concerned about chance of perforation, then migration, seedings, all these things when we are doing a biopsy. And we don't know whether the biopsy aspect can be a factor in the outcome finally. So are you, will you give a neoadjuvant without a proper biopsy with a cytology or with a radiological picture?
So we are doing that for upper urothelial. I think that's the major issue. There was a time when we used to say, no, let's try to get a biopsy, but it's impossible. We eventually understood that you're not going to get it. We are okay with radiology plus cytology. And we know...
If cytology is not there, with a definite radiology, will you give
So we have done it. We do it in practice. The reason is there are sometimes you extrapolate a little bit of settings, but you eventually we have done it. But ideally it is radiology plus cytology. That's the one we should take up.
I think the thing said, biopsy is must. If it is low grade, there is no role of chemotherapy. You are necessarily subjecting the patient for chemotherapy. If it is high grade, there is no need to having muscle invasion and all. In upper tract, you don't see muscle invasion. High grade, go ahead with neoadjuvant chemotherapy, provided the kidney is okay. Yes. If the kidney is gone, there is no point in waiting. You just remove this off and then give adjuvant chemotherapy. That's what we do. And there is an article from Surana Matin from MD Anderson, way back before pandemic, where I used to go to MD Anderson at that time, and he has published a lot of cases in this segment when he suggested for NACT in such patients who have got good kidney function and the high-grade disease.
Right. Last question.
Yeah, so, that's the way we are moving. That's neoadjuvant for those specific patients.
So in bladder, we know that carboplatin is going to be inferior to cisplatin in adjuvant setting. It's the same biology. I'm talking about pure bladder. It's the same biology in upper tract TCC. Then do we also correlate, though we don't have a robust data, but do you think that carboplatin is definitely inferior in upper tract setting for adjuvant compared to cisplatin?
Yeah, I think we are extrapolating the same data. We say carbo is inferior.
Then in that case, why not to use neoadjuvant in high grade, obviously, malignancies to the more core? Obviously, why are we waiting till 2023 for having randomized trial? What's the caveat?
So we were waiting till 2020 to even say adjuvant chemo works in upper urothelial. So once we accepted chemo works, then we started moving to the upper.
So one quick thing then, given a choice, you would prefer NACT over adjuvant in another couple of years' time in future?
I would, that's the reason why I put all those advantages, disadvantages. I don't think one can make an absolute one statement and say, for all my patients, I will do this. I don't think so. I think it will be a much more nuanced approach, but there is definitely a place of neoadjuvant chemo for upper urethra. I would say yes.
Thank you, Dr. Amit Rautan. I now invite Dr. Makarand Kochikar, who is a consultant uro-oncologist from Meerut, to talk on upper tract urinary cancer, which is open versus MIS, lap, and robotic approaches. Is one better than the other? So you've got 9 plus 6 minutes.
Thank you very much. At the outset, I would like to thank the organizers, and the greetings from both the hospitals is a recent one, which we started about a year ago. We are talking about upper tract urothelial cancers, and we do mean that is coming from either renal pelvis, ureter, or intramural portion of the bladder. We are not talking anything about the conservative treatment. I think the mainly focus we are talking about what's the gold standard. Is it open or a laparoscopic or minimally invasive? What is important is I think we have to understand the biology is not the same as what you get in a bladder cancer. They're mainly high-grade, high-stage disease. It's an aggressive disease. So we are dealing with something, a disparate cuisine as compared to a bladder, and so we have to be very, very aggressive. And obviously, because there is a high chance of recurrence in the ipsilateral kidney, frequently multifocal and contralateral kidney, less chance, that's why we do standard radical nephroureterectomy. To my mind, whosoever does it, either open or minimally invasive, I think you need to take a bladder cuff. I think important that we miss out on lymph node dissection. We should not compromise on that. R0 is essential, and do not violate the oncological principles. So whichever technique we use, I think we should have these kind of factors very, very important. So why are we dismissing? We all know the cosmesis, the blood loss, recovery, post-op recovery. So minimally invasive is better than open. But why we are discussing? Because as I said earlier, it's an aggressive disease, needs a radical nephrectomy with a bladder cuff. Many times in the practice, we do see a residual stump, and we also see a spillage during surgery, high chance of bladder recurrence. So we need to have a technique right. Lymph node dissection is not done in many situations, which is important factor. And nowadays, we talked about just NSCT. We are doing radical nephroureterectomy post-NSCT, so this can be a challenge. So let us find out which technique gives you R0, also gives a better outcome in terms of recurrence-free survival, cancer-specific survival, and also important is a bladder cancer recurrence-free survival. I think many studies do not look at that. And we all know about morbidity and cosmesis. We're not discussing here that. So let us look at the techniques as a comparison, and then we talk in few slides about the outcomes of different studies. So techniques, what we have, a standard. We have open surgery, like a midline incision, like we do for a cystectomy. I think you can get a good sort of a complete nephroureterectomy, take periureteral tissue along with this, and a bladder cuff is extremely important. And I think I repeat and say we need to do a good lymph node clearance. That's on the left side, that's on the right side. The extent is already been dissected and decided in many studies, so we have to follow that. Sometimes we do a cysto prostatectomy along with that also, and I think midline incision helps that. This midline incision, transperitoneal, in elderly patient always gives us to a sort of a prolonged recovery, ileus and other things like a cystectomy. So what you can do is we can do in a total extraperitoneal dissection. Do an hockey stick, something like a transplant, get an extended like a pediatric nephroureterectomy, but important that you take a cuff of the bladder, and also important that you do good pelvic lymph node dissection. Many times in the past, we used to do 2 incisions, one in the loin, extraperitoneal, and then take, this is a huge sort of a cuff of the bladder has been taken, so you can do a midline incision. So this again can be done extraperitoneal. Previously, we used to do something like, TUR resection of the ureteric opening, and sometimes we used to do an incision around the ureteric opening and try and do something like a plug. But this is useful only when you do not have much disease in the lower ureter. And I think if you have an extensive disease in the ureter, this technique is not going to be useful. And again, prolonged catheter, leakage, lymphoria, everything used to be there. Now let us come to the lap. Standard. Now we do lateral position, do transperitoneal. But I think the distal ureteral management changes. You change the position, exploration through the retrieval incision to complete the sort of position in the bladder. I think these are things we have to address in lab. Many times we have found that you just put small clips at the vesicureteric junction, and you do have small stump and a recurrence there, and the lymph node dissection is not done properly, and this is a big, big concern. Now, managing the distal ureter with a bladder cuff, without a spillage. I think that is what people talked about. When we talk about resection of the ureteric opening, that is what not people wanted to. The first technique was established by Indy Gill many, many years ago. And what he did was during lap nephrectomy, the dissection of the upper and middle ureter was done. And he actually put a needloscopic sort of small port, 2 small ports into the bladder to get sort of a read of sort of intravesical portion, technically demanding taken a bit of a longer time. Subsequently, a good friend of mine, and we worked together many years for different ideas, Dinesh Agarwal from Melbourne, Australia, he presented his work way back in 2008. And this was all sort of born out of the discussions we had many times. First thing is what you start with is cystoscopy, then you do a ligation of the ureteric opening and the release of the distal ureter by in lithotomy position. Then you do a lap nephrectomy in a lateral position, and then again make it a flat position, small incision in the iliac fossa, and then sort of retrieve the specimen, and then close the bladder. This is how it was all discussed. So what it was, you actually sort of put here a loop here by resecting here, close the ureteric opening, dissect it out, using the endoscopic endo loop there. And this was all idea when came many, many years ago. Me and Dinesh worked with Dr. Gaur with a laparoscopy, retroperitoneoscopy many, many years ago. And years together, we have done a lot of sort of work on sort of different techniques and in nephron-sparing surgery, as well as sort of upper tract ACC. Now, subsequently, he has come out with another technique. And this technique was another loop, which was made by an Olympus company. So what you do is basically you resect it, put a sort of a loop around here, and then sort of release everything. And there's also a cutter here where you can sort of cut that sort of loop here. He has published a long-term sort of an outcomes because technique is one we talk about. So we said, let us look at sort of a different sort of studies. So this was done in Australia. And almost in 76 patients, it was found that it's fairly good sort of technique. It minimizes the tumor spillage. So I think this is one technique you can think about to avoid the spillage itself. And in this study, they compared the endo loop as well as poly loop. And I think this is a wonderful idea in minimally invasive surgery. Yes, I think people who are expert in robot, I think the only thing is you have to dock the robot probably right angle to the table, and you can do it in one incision. And this is on the right side, this is on the left side, perfectly possible. You can get the kidney here, dissect the whole kidney out, everything is in front of you. And here, basically what you can do is you go around the vesical pedicle, isolate the ureter, and actually